morning, good afternoon, and good evening to everyone all over the world. Welcome to this MOH Connect, again from Germany with Dr. Erika Mendoza, where we have previously a great experience doing hands-on workshops with some patient life cases, which bring a lot of knowledge and experience to everyone. This is actually one of a special kind of MOH format that we do, along with the MOH talks, the normal webinars, but also the MOH Essential, the new format with the educational content from Professor Eber Drabe, also as well as the MOH Focus, the MOH Bulletin. That's why I really encourage everyone to go to the Medical Online Hub platform to see the different material that we have published there. It's not only in English, but also we have French, we have Spanish, and we have Portuguese, a lot of languages differences there. So please feel free to navigate over the website to get the knowledge. And because at Sigvaris Group, we always strive to promote the exchange of the scientific knowledge on a global scale, while also giving you the possibility to actively participate in the discussion via our chat function. So please feel free to send over any questions or what your comments in the chat or the Q&A, and our great experts will be happy to answer you. MOH, or the Medical Online Hub, is actually bringing together the medical expertise from around the world to discuss state-of-the-art topics in the field of the venous lymphatic disorders. So today, we have a top-notch experts from Egypt, also from Germany, with us to bring their expertise to you. On a personal note, I'm really looking forward to this event and some very dynamic, lively discussion, and I wish you all a wonderful and a fun time during this MOH. Having said that, I will have the pleasure to introduce our main principal moderator and also our expert speaker together. So first, I would like to warm welcome Dr. Wasila Taha. Dr. Wasila Taha is like well-known expert. It's really hard to find the words to start with, but as we call her the Cleopatra of the venous lymphatic world, she's more from Egypt. She's the General Secretary of EVALA, the Egypt Africa Venous Lymphatic Association, with a great event happening every year in Egypt. Also, she's a consultant, of course, in vascular medicine and geologist. More than 25 years of experience in vascular ultrasound. I'm sure that you have seen her in different successful workshops all over the world. She's the chef of the TDC, the Duplex Center, and also co-director of the Vein Clinic of Egypt. She's the fellow of CHU, the Center Hospitalier of Liege, Belgium, and also a member of the ARDMS, the American Registered Diagnostic Sonography. She is also international ambassador for Africa at the AVF, the American Venous Forum, and she's also continental chair of NENA, or Near East and North Africa, at AVLS, the American Venous Lymphatic Association. She's also a member of the famous UIB, the United International of Phlebology, in the Educational Committee. She's a lecturer in many courses in Egyptian Vascular Fellowship. She has a great contribution in the national and international vascular conferences and congresses everywhere, and she received a lot of awards. One of them is Best Submitted Abstract in the UIB chapter meeting in Krakow, Poland, was really a big success in 2019. And she is also the inventor of the ABSV, the ankle-bake systolic velocity, a parameter to assess different degree of peripheral ischemia. I can continue more and more, but I think we'll need another 15 minutes to continue introducing Dr. Wasila Taha with her great contribution to the medical and the venous lymphatic community.
Thank you so much. I feel speechless, Mahmoud. I have never been introduced in such way. Thank you. Thank you so much. Thank you.
Yeah, of course. It's really our pleasure and honor to have you, Dr. Wasila, with us. And now I will also introduce Dr. Erika Mendoza, which I have the honor and the pleasure to be again in her clinic. Of course, Dr. Erika Mendoza, I need also another 15 minutes to introduce her. She is specialized in the venous investigation, Duplex ultrasound, and treatment with preservation of the saphenous trunk, JIVA, CHIVA, with the vein office in Wonosdorf, where I'm now with her in the clinic. Again, thanks so much for inviting and having us with you. She has running this since 1997. She's authored books on duplex ultrasound. I can see here in the background of her library a lot of really great achievement, great references, books, studies, research that, that she has done in the duplex ultrasound. She has also her own courses online and offline. It's really a great contribution to the community. She's also having different courses in different languages. So she speaks, I think, if I'm not mistaken, 7 languages, I guess.
Oh,
German, English, French, Italian, Spanish. So you
yeah.
name it. She provides a lot of lectures and hands-on workshop in Germany, but also in the international meetings. She's now the General Secretary of the German Society of Philology since 2015 and the current president of the EVF, or the last EVF, president of the German Philology and Lymphology Society meeting in 2022, also the president of the EVF meeting in 2023, Berlin, president of the German Society of Shiva since 2000, and the member of Educational Committee UIB since 2023. As I said, I can continue again and again introducing Dr. Erika Mendoza, but really, I'm honored and also feeling really delighted to share the stage with 2 of my own models, Dr. Wasila Taha from Egypt, my home country, something I'm really super proud of, but also with Dr. Erika Mendoza in her clinic. So with that, I would like to hand over to you, Dr. Erika, to start your presentation.
Well, thank you so much. And I think Wasila and me are very honored to have you with us that initiate this MOH thing. And I thank you personally because when I told you, oh, it's always talking, why don't you do hands-on? You immediately said, yes, we'll do it. And I hope that this will be a model to spread over the world because I think lots of people have things to show. So let us start with a little introduction. I don't know, Wasila, do you want to say something? Or later on?
Yes. I beg your pardon, Erika?
Do you want to say something now or just when I finished my talk?
Yeah, no, ma'am. I'm just, I echo what you said. That I'm truly honored being with us with the MOH for the first time. I found it's a wonderful idea to change the platform from just lectures and online lectures to a real ground with the hands-on workshops. This is really a genius idea. I really appreciate this and I congratulate this idea. Thank you.
Thank you. So I hope I had an issue with the patients. Things have changed. I don't know if everybody has perforating ways to show, but I hope this will be the case. So I will start with my little short presentation. Everybody sees it, yes? Okay. About ultrasound diagnostics of perforating veins, which is supported by Sigvaris, as you all know. The perforating veins, we know they had own names like dot in the middle and upper thigh and hunter on the adductoric channel, which now they are called medial perforating veins at the thigh and the adductor channel and proximal paratibial vein void. These ones are often involved as a source of reflux. And then we have lots of perforating veins on the calf, like on the inner part and on the back part of the calf. Unlike the ultrasound investigation, you see, there are perforating veins here, but they are not uncovered by the liquid, the contrast media, because they are not involved in recirculation. So we only have to investigate the perforating veins that are enlarged, will be obvious to our eyes. And the question, when I started 20 years ago, often it was discussed, all the dilated perforating veins are pathological. And I kept fighting and saying, no, only those with a diastolic outflow are pathologic, because if you have an enlarged vein, like a very large vein, the blood that will drain through the perforating veins will enlarge also the perforating veins secondarily, but they are not primarily ill. So you see, this is the tibial bone, you see that perforating veins can be enlarged but draining. And this is very, very important to have in mind. So what do I mean when I say systole and diastole? Systole in the leg is when we make a muscle pump or we compress the calf so the blood goes up to the heart. And then we wait what happens in the deep and in the superficial vein, looking at the flow in the perforating vein. And if in the diastole, the blood goes down through a varicose vein or through a healthy vein and drain to the deep vein system, we have an inflow to the deep vein. And this is the phase, the diastole, where we have to look at the flow of the vein to determine if it is refluxive or not. You see here a very large vein at the calf with a large varicose vein draining here. And in systole and diastole, you have a draining flow. So this is obviously a large vein, but it is not a pathological vein. Other thing is this. This vein is also on the tibial bone. This is a person that had a deep vein thrombosis, and you have an obvious outflow through the perforating vein in diastole. So this vein is really pathological, feeding the superficial recirculation. The same, this one, we have a great saphenous vein longitudinally. Well, this one is the way to the thigh, and this one is the way to the knee. And here we have a competent part of the vein. Here we have a refluxing part of the vein. And here we have a dot or a medial perforator of the thigh with a large reflux volume filling the great saphenous vein to the knee. So sometimes perforating veins are the reason of the varicose veins, and mostly these are located at the thigh and not at the calf. One very important thing is when we have occlusion of the deep vein, perforating veins may help to find a bypass for the blood, to help it go upstairs, as I already said, to the heart. So we find the deep vein occluded, and then we have a systolic and diastolic outflow here, and a flow, anterograde maximum flow in the great saphenous vein. You see here the great saphenous vein coming from the foot, which is tiny. Then we have the void or the paratibial perforating vein below the knee, draining the blood from the deep veins to the superficial one and filling this very enlarged great saphenous vein, bringing the blood upstairs. And here you see the classical thing, perforating vein in the knee fold. The saphenophymopopliteal junction is this one, which is healthy. The saphena parva, you will see it here, little there. It's completely, the small saphenous vein is completely healthy, but you have a permanent retrograde flow in diastole. You wait, this is systole, this, and then in the diastole, we have a long-lasting outflow in the perforating vein in the fossa poplitea. A very strange and not so often to be seen perforating vein is a so-called transtibial vein, which happens after a bone lesion. Like here, you see that the tibial bone is disconnected here, and then you have an outflow from this. And I only can invite you to our next MOH, which will be Saturday, 21st of September, because I will make a foam sclerotherapy of this guy with this paratibial perforating vein. So everybody, please have a look at the calendar of the MOH. This is an interesting thing. Just to summarize, re-entry perforating veins are always competent in systole and in diastole. If the perforating vein is enlarged, we will have an outflow in systole, but the diastole, when we release the calf of the patient has lowered the toe, will be into the leg, to the deep vein. And if it is an escape point in the diastole, we will have a reflux. And I think we will have the occasion to see some of these cases this evening. We have a little bit of seasonal flu in this time, and I didn't arrive for one of the patients. I hope everybody is coming, and so I hope we will have full session. Just to remember, this is a paratibial perforating vein, and you see obviously much longer than 1 second. These are lots of seconds, 5 seconds of reflux through this perforating vein. In that case, it is obvious you have a reflux. Okay, so in summary, you find perforating veins divided along the varicose veins to investigate, and you only have to investigate those that are really wild. And the important phase to determine the reflux is the diastole. and the diastolic drainage through a perforating vein often marks the distal re-entry point of a varicose vein. The dilation of the perforator depends on the amount of reflux, and if it is a draining perforating vein, if you pull out the reflux, like with environmental laser therapy or heating occlusion or foaming stir or operating, however you close the reflux, the perforator will again get closer and you won't see it anymore. The reflux and systole is seldom, and if you see it, you have to think of a problem with the deep veins. So this was a small introduction, and I would like you to make the first 4 questions. I have to change a little bit the settings, so I will leave the place, and Vasila is there for questions and for the...
Thank you so much. Yes, thank you so much, Erika. It was an excellent introduction for such an important item in our specialty for the perforator veins. And as you mentioned very clearly that they are not just a vein. No, it is very important to diagnose is that a simple re-entry perforating vein or a pathological incompetent perforating vein, which really dramatically change our line of treatment. It's perfectly well mentioned. And if we have some time, we can see the history or the saga of such perforating vein by the anatomist first mentioned. Now we have the poll. Okay, thank you, Khaled. I'm not sure if everyone can see the poll questions. Mahmoud, everyone can see it now?
Yeah, I think now it's
okay.
visible, and we'll just give like 30 seconds.
So the first one. So the first poll, the perforating veins are always part of the recirculation pathway in varicose veins. Which answer is wrong? Number 1, a dilated perforating vein is always causing the reflux in varicose veins. Number 2, for the diagnostics of pathology in perforating veins, the interesting phase is the muscle diastole. And number 3, a draining perforating vein is defined as having flow from superficial to deep during diastole. We have 1 minute to have the results of such voting. Please vote.
Thanks so much, Dr. Wasila, for sharing the poll questions. So now we got the patient in the clinic, and as you can see, we have a special setup in the clinic, which I think can really help so many of vascular surgeons, how they can set up their clinic to get a different perspective when they are investigating the patient.
I like the way, because there is a step, and now we have the results of the poll. A dilated perforating vein is always causing the reflux, with 62% for the diagnostic of pathology in perforating vein. 21, a draining perforating vein is defined as having flow 18%.
So
I have a great job, Erika.
I hope, yes, but yes, which is wrong. Yes, okay. I hope yet after
61, 21.
So the first patient is here, and so I would like to start doing the investigation, if that is okay. Everybody's fine with it, so I will share my screen again. I hope it will run like it did earlier.
I like the setup. So it's very important to see that the machine of the ultrasound is on the right side of the patient bed. This is very important. And yes, in the level, very comfortable to the operator, so he can do the provocative maneuvers much in a comfortable way, I mean. So your setup, it's very well done, Eric.
Thank you. I think so, because I'm only doing this. And of course, we have lost our. We saw everything.
Now we have it
earlier, and of course, I have lost my computer. Just give me 2 seconds to find again my laptop, my I have a ball, perhaps you can see on the image. I have a ball on which I'm sitting because this helps me not to get my back stiff. And so
Can we see the ball? Could you focus on the ball where you sit?
And another thing which is
Yes.
that I have three here. So when I make the ultrasound, I don't have to be like always looking to the other side, and I can look to the leg and have the second three behind the leg. This is good for my neck. And also I have to find,
Perfect.
I have to connect.
So what is the way when you start? You start from the back with the small saphenous vein, or you start with the great saphenous vein? What is
Usually
your
I
way to
start-
scan the patient?
Yes. Usually I start at the groin, but in this case, no. Do you see the image? No, you don't see the image. Is that true?
No.
I share it now. Share. Where are you? Here. Do you see it?
Could you explain us the clinical of the patient, of your
Yes.
patient, Erika?
I will
The
start
clinical manifestation of the patient.
first name you.
Now we can see the ultrasound screen. Yes.
Yes.
But a little bit about the history and the clinical manifestation of your patient, please.
I have seen this patient many years ago when he had the muscle veins thrombosis in the left cup, and we treated it with anticoagulation and decompression. Then we did an interruption of the tributary because this was having a varicose linear. And today he came back after lots of years and asked me because he has new varicose veins in the back. And all shielding it.
Yeah.
Martin, I'm going to over my couple of I will put the slide on and have a picture of him. Can you please come and see my clip? Name average. And here it was lines there and here. And you'll see here some lanes. It's not so good. Are you selfie? Does somebody see what map? Yes. Here you see, when you look there, you see some lanes. This is not very important. I mean, you
Oh, we see it on Mahmoud's screen. Yes, we can see it.
Screen, yes. If you think like, oh my God, this is not so horrible, what is she doing? But when you see the inside pictures, you want to understand what I'm doing and proposing, and that notices like something is happening here. When he sits down, he has like pressure, and after a long day, he has also pressure. He has come very early, so there is no speed acceleration or nothing yet minimal. But as he already had thrombosis, he wanted to get it sorted with problem early, and he was very spontaneous because this morning somebody said he can't come, and he just stepped in. So thank you so much. This one was for you, Matt. And so I will, in this time, take a rinse emerald. I will show you because you asked, I'm an engineer. Because you asked how I usually start the investigation. We did this another time, or we can release. Usually I start on the groin on the right side, always the same. Yes, I don't have to correct reset. And
so you are on a venous setup, please.
Yes.
We can see LEV. So it's a very first you have to select the appropriate setup.
Yes.
This is very important for the beginners.
Yes. And sometimes
I can see on your screen, so lower extremity vein setup. So you have the appropriate setup for the venous scanning. We can see now the common femoral vein, yeah.
You see the common femoral vein here, the artery, and the subvenous
Yeah.
vein. Like the Mickey Mouse.
Yeah. Yes, the Mickey Mouse side, yeah.
We can put the color inside, and we can put the
artery pad style, perfect, yes.
Just to say, okay, the eye is alive.
I phasic weight walks, yeah.
Yes. The next thing I do is to sort out that there is no problem with the deep vein and to do like compressing. Yes. You can do this in this trial position or standing position, but this is the demonstration that there is no outtake and documentation, that there is no thrombosis in the deep vein. when I investigate the sacculofemoral junction, which is this one, and I have always to make
So
sure.
you start first with the B mode, Erika. No catheter at the first. You start with the B mode. You identify your vein, your common femoral artery, common femoral vein, the junction, the great saphenous. So, and then you put your color box.
Yes.
All right.
You see in the longitudinal, you see the valve.
Yes, you can see the epigastric vein perfectly well with the great saphenous, the junction, the terminal valve is very well seen. Yeah.
You see a wonderful thing, which I didn't expect us to have here. This one was the drain from the epigastric vein into the deep valve.
Yeah.
So yes, flow from the epigastric vein. This is largely the sacculose vein. Is that visible in your display also? This one, this is see, and the little spot all reflecting needles. Okay.
It's like that's not good.
There's a treatment for the mobile phone in the back. So then I go back to did you know it? I could see I made the compression of the car, and there is this artery crossing, which is always disturbing when we do operation. And you see a little bit of inflow from a deep vein, from a condition with a deep vein, but there is no reflux. Maybe somebody see the shoulder fruit, I'm not going to be on job.
There is no reflux from the deep system, right, Erika?
No reflux from the deep system, no. And then now
From the deep system, there is no reflux.
you go down, and we have the pelvic. I go down, opening it as a great sucking on the vein. You know this Egyptian high here, sucking.
Yes. Yes. Can you go much more for the depth?
More
For the depth, less deeper, maybe.
sort of like this. Is that fine?
Yeah, it's perfectly seen now. Yeah, the saphenous eye or the Egyptian eye. Yes.
So this is the I have the troll. Putting the skin, you can see that the levels are lower. Yes, it goes like allowed to see them monitoring. So now I put the key down and to have a put image, I tilt the troll. I don't do it horizontally, but I tilt it a little bit to get a better information. And then the crowd compression, and there is nearly no flow in the sacculous vein. So the next one, we make a total ventilation, yes, and monitor, and there is nearly no flow. But the patient has some tributaries, very ones. And so we will make the thing I've already done other times. The use Monday. The patient is recovering, yeah. As you want to lift his leg up, we wait some seconds, and you will be surprised what happens then. That's the moment.
So you mean before this maneuver, you had no reflux, and when you ask your patient to lie down and then hop in the same level, you recheck for the reflux, and you have now a very long reflux.
I wanted a lot. I didn't find it complete, so we are using this.
Put a mark, Erika, where you want to recheck. Put a mark by the pen.
Yes, I will just talking, and I'm out of my understand. It is not too much, but you see there is some reflux. And
no, there is, it's long.
Yes, it is not too much, but there is a reflux. So sometimes you see particles that.
It's more than 1 second, Erika.
Yes, now far more than 1 second. So 2.5. So sometimes this allows you to discern between very, very slow reflexes. So then I turn around. I don't want to do the complete exploration because I have 3 more patients to show you. The right leg is the correct, the healthy one. So I just show the photocopitia. I usually make a longitudinal scan of it. Then I put the color just to make sure that everything is fine. The game here, sorry. The leg is seems normal, it's normally contoured, there is no issues. Always, please do not forget to put that on the compression. This image is very important in the records. And you have to once check organizatively the flow in the artery. Because if you have no good flow here, you have to think about compression. I know that this is not the correct way to investigate arteries, but you have a good for three-dimensional, why is it inverted? Okay, it's three-dimensional flow, three pulse flow in the artery, and so we are happy with this. Now, you have the jungle.
The vein is compressible. You can see the vein and the small softness. You can see it.
And this is the side step that for me anyway, because I'm going up, as you see, I'm going up from the knee forward.
Yeah.
And measure there. It's always don't forget to measure inside the Giacomini, but this is okay. And then go down.
Erika, there is a question. Erika, I beg your pardon. There is a question in the Q&A box about the provocative maneuver. Maybe if it's now you can do some of the provocation or provocative maneuvers.
Yes, you will show that all in.
So what you are doing is an
I don't hear. I mean, I also hear. We'll dive back and see what that sounds in the room. Okay. So I have some provocation maneuvers. The classical one everybody does is compression and release. Yes? You want to do it on the day because there is a standard to be sealed. What? Compression, release. So another one can be toe elevation. It is by CR. One more time. But not I know. You know it. So toe elevation, one time. No, we didn't do it properly. I want more. I know talk. Perfect. So this was the toe elevation movement, and this was the back to erotic movement. These both maneuvers are those I did the most often. If I got heavy with my throat, I do the dependency maneuver, laying down the patient, and very, very seldomly I do a salva. Why? Because I always investigate in standing position, and if people keeps doing Valsalva, they faint. So I do very seldom with Valsalva. I don't like it because people tend not to do it properly, and you often have movements and so on. So we have here an interesting thing because we have a perforating vein. How to discover a perforating vein? This is the fascia. It's a venous fascia, the nasal fascia, the saphenous compartment. And here a tributary goes out of the saphenous vein. Right? We have to handle what's the phase of the vein. So it is.
We can see the saphenous ligament also. Could you put on the saphenous ligament the echogenic line between the two veins? Yeah, very well defined. Yes, perfect.
And here you see that the tributary is piercing the muscle fascia. So this is a perforating. If it would pierce this one, then it would be a tributary. But as it goes down inside the leg, it's a back on. And now we have a look on the jaw. First, with compression, nothing happens. Things might here. One more shot. And then einmal. If it is diastole, jetzt nochmal einmal Video with einmal umtoppen, nichts mehr drin. With the diastole, nothing happens. When you moved up the toe, that was strongly, but when you release it down to the floor, nothing more happens. So this perforating vein can be defined as self-heal. And we could find Venous in this.
So Erika, could you please, when you put the color box, could you please explain a bit by the direction of the flow on the color scale on the screen? Put the color flow, please, because a lot of us they don't know about the direction from the color mapping.
Okay, so now we go to the left leg, which was the one the patient was consulting. And if you have a look at this, I want to make this screen.
Yeah.
just to remember, this was the right side, and this is the left side. You just see that there is a difference in the diameters of the Giacomini vein. And if you go down, you see lots of veins here, lots of. And you see one thing, a very large subfascial vein. This is the muscle vein there, the artery. And then now we have its color back. And this is what Vasila is telling us.
Yes, please. Yeah.
That this upper part is red and the lower part is blue. Because if you make the change like this, and you remember that the black flow in ultrasound is defined as no, this away from the probe, the red is going to the probe, you would have the wrong results. So by definition, when we investigate vessels, it has to be the upper part has to be the red one, and the lower part has to be the blue one. And so in ways we expect when we explore them that we have mostly blue flows because the flow is going from superficial to be from down to upstairs. So if I compress, we see something here in these veins, which should not be expected. Have a look at these veins. They should be blue, but they are red. This is because the health and the valves on these veins do not close. So let us let the longitudinal view we can do this a little bit. The longitudinal view, and we see there is a systole and anterograde flow in the gluteal vein, in the Giacomini vein, and when we go here, we see where the muscle vein starts, and we see in the muscle vein we have a reflux after decompression. This is what it's in my mouth on top, which is better to be seen after elevating the toe. Yes, this is
Could we try with the Doppler, pulse Doppler to copy? Yes, please. Thank you.
Let's see here. Elevate and down. Compression. Now we have slightly like a little bit of time.
Yes.
We see when he moves, because he's standing in the correct position, you always have like I say this is a kind of flow. It goes up and down. You want to have it in another place here. And here you see that the reflux in between the muscle contraction is lower than like one second.
Erika, we have in the chat a remark. I cannot surpass it. An insonation angle, but because you put your cursor on the Doppler at 90 degrees perpendicular to the vein, an insonation angle of 90 degrees does not produce adequate waveforms to be studied. What you would say?
I would say that most of the time I investigate like now, where the vein is just coming out to the
This is from Wadi Nito. Don't know. Yes, Wadi Nito.
In this case, we have the vein perpendicular to the probe. Yes, in the probe measurement point, which here, this is the vein, and the measurement is measuring in this direction. So let me just finish this place, and I can explain to the experts.
Okay.
Here we have
another question: what kind of ultrasound brand? This is a GE, I can say. We can see at the left, very most left. Yes, GE. It's a GE machine.
And now just have a look. This is a very important place of investigation. This is a perforating vein between deep veins and the Giacomini vein. And you see, and there is a long-lasting starting here, 1 to 3 seconds, and I start to stop the screen. Then do it again. It's what it's here. On the lesson. We wait and wait, and it runs and runs and flows and flows and flows. This is a real long-lasting reflux in diastole. You see this reflux in because it is above the line, and it is after he has moved, so in diastole. So now I come back. If I make a longitudinal investigation, yes, like here, if I measure in this vein, of course, I should correct the angle. But to tell you the truth, we are not investigating arteries. It is not about the flow velocity. It is just
Erika, so you are putting now the color boxes. So we have a question, very interesting, from Erwin Tunder. He doesn't need any introduction, from Netherlands, about the scale of your color, scale PRF high. I think with the color you have 16. I think so. You had 16. This is Erwin, huh? This is not me. This is Erwin Tunder.
So I was trying to explain that when I measure here in longitudinal view, it is only a semi-quantitative information about the flow, because we can't, the saphenous veins are parallel to the skin. We will never, with inclination of nothing, find a flow inclination so that you can never inside the vein parallel to the vein almost like you are supposed to do in arteries. This is why I love to do it like this and tilting the flow, where you have a far better flow measurement. But the thing in veins is not about the highness, the velocity, but on the duration of the reflux. And this is the same even if the flow angulation is not the perfect one. So now we go back to Erwin Tunder, right, Erwin?
Now you are in a 15 or 16, 15 centimeter per second. Could you play with your velocity, color velocity scale? Put it down a low scale. As you see, if the you will get much more sensitive imaging. You are on 15 now, Eric.
Yes.
Could you put down your velocity scale?
Let me try and answer you. So normally I'm 15, yes, and here we see this perforating vein flowing outside. If I play with the PRF,
Yeah.
it will have 45, 60, yes. And
now we lost everything with 100. We lost everything.
It's gone.
Yeah.
Yes? No longer a reflux. Not in PW, not in tidal. So we go down with the PRF again, go down to 64. We have a little bit of it.
Yes.
We go down to 18.
15 now, yeah.
See that the curve is adapted to the better reference with the framing, the repetition of the frequency. So this is the correct one. You have to have a low one to measure veins, because if you have a too high pulse repetition frequency, you will not get the information you need. So coming back to the applications, here we have the Giacomini vein, which is enlarged, is long standing here. Here there was across a traumatic strong saphenous vein thrombosis when he had his muscle vein thrombosis. So this is a little bit of not normal anatomy. We are trying to find the propitial saphenopropitial junction. It could be this. It could be this one. Yes, but it is difficult because the anatomy is changed through the thrombosis. And this will be my ears. Yeah. So aesthetic the patient is feeling well. And so now let's have a look. Let's check this small saphenous vein at this level. You see my probe is tilted. And you see the small saphenous vein is competent at this level. I go up and up and up really well. Here I wouldn't say that one is the small saphenous vein. I couldn't explain. So we have to think about what happened to the blood, to the reflux. We had a perforating vein. We have failed in the Giacomini. That was our perforating vein. We filled the Giacomini vein. We go down. And this one we should define as the saphenopropitial junction. We can just settle on the floor here inside.
Erika, there is an interesting question from Attila Puskas. I pronounce well the name. When you place the sample for your pulse Doppler to test the perforator flow in diastole, which is the right place to put it? At the muscular fascial level? This is the question.
Yes.
So could you demonstrate where you put your cursor?
Okay, let's come to that. We have the small subfibrous vein here, that's tributary. This one. You follow the tributary, and you see here it pierces the fascia. Yes? So let's have a look where. Then short. I have to start with color because the change of the angle is better in the color. So I start with color. So you see now, we will make a mistake. If you see now, you think that there is. No, my explanation doesn't work. Yes, you could imagine that here is an anterograde flow because there is a blue, like a blue flow. But if you then contrast it with this, here, you see status erroneous. You have to invert it. You have to invert it and have the red one on top. So now I put the PW and I'll show you exactly. You have to measure the perforating vein on the place where it pierces the fascia. So again, patient is standing and moving a little bit. So it is difficult to decide if it's going in or out. Now I make a cup conversion and release. And you see that for a moment, this was the cup compression release, and then it is an outflow. So this is an obvious refluxing perforating vein. And the best place, like here, you have to find somewhere where it goes perpendicularly to the skin and pierces the muscle fascia. You can see that the patient is always moving a little bit, like with if you ignore it properly. So we will make this album, therefore it's make it. Yeah. We will try while sitting down, and we will not keep moving the calf muscles. And I will try to find the way from the hemorrhagics, the perforating vein, on the relaxing. Here you see very, very well scars from the old superficial vein thrombosis. You see this? The vein is
Yes, we can.
Yes. Here is scars from the old thrombosis.
There is a remnant of the old phlebitic changes of the vein. Could you put it again, please, Eric?
And works. Here.
Yeah, because this is very important. Yeah, we can see it now.
Yes. Here you see there is something positive like the data we put together. But here we see material inside the vein here. Yes. And this is like little scars. Here you see very this one is a little stuff.
Yes.
Always the market on change.
If you put the color, it will be like a double channel here.
One person the color here with succession still. And what's the place?
Yeah.
Where?
Yeah. We can see it now. Yeah.
Okay. And now I want to try and find the perforating vein. And then we have to release this patient. Yes, to work. You left all the pain on his feet on, waiting for me. Just sit down here. What is it perforating? What is when you are started? You know, I'm not used to make the ultrasound and CT in persons. There. Then there. It's also interesting when we got the CT, the perforating vein is much larger. You see that? When I want to, like here it is.
Yes, let's see now. Yeah. Could you put your color box may be much longer, so the rectangle less wide, but longer than this. So you can get all the perforator in the same image.
Just a second. Give me a second. Technical than me. So in this case, it is less volume moving, and you see when I press, it goes inside, and when I release, it goes out. Yes, this is classical determinant for now I changed the product box.
Yeah.
This change. The place. Right here, like the perforating way has kind of horizontal flow. It doesn't go to the depth, it goes like horizontally. We will have another cases with only on perforating rates, right? I think we can for this guy. Thank you so much.
We would like to thank your patients. We can applause her. Thank you so much. Erika, we have a great question from Ashish from India, the big finger of clacks. Professor Erika, in what percentage of patients in your practice do you come across a diastolic refluxing perforator with deep system pattern and the saphenofemoral junction competent, being so responsible for the superficial vein reflux?
Well, if we say the deep vein is competent, it is less than 1%.
So less than 1%.
He had to reflux was the deep vein. This is why he had to reflux it, perforating vein. But normally you have only draining perforating veins. It's very seldom to find. And we will have later on the lady which reflux to the perforating line, and she is refluxing as the source. He has the perforating vein at the sun. Just give me a second.
Oh, all right, but thank you, Erika. I wish to say that really the perforator veins, we are in another era with the advanced ultrasound skills like we see now Professor Erika Mendoza. It has changed all our practice. But I would say that after the Dutch SEPS trial, there is no more room for the management of perforator like before the Dutch SEPS trial. So this is what a prospective, a randomized, a multi-center trial with, I would say 200 limbs with 2 arms with the SEPS, so the surgical arm and just the compression arm. And there was no big difference or significant difference, between the 2 arms. And since then, with of course the Duplex guided procedures comes in our practice early in this century, 2000 something. So it makes all the difference nowadays, especially with our devastating patients with the ulceration, with the venous leg ulcers. It has changed a lot with the guided procedures, and of course with the room of compression nowadays. But it's we still have to, for more and more, I would say research, maybe with the idea of SAPS versus compression. Maybe these days we can do the foam guided ultrasound foam sclerotherapy around the ulcers versus compression in different arms. And we have our ongoing in Egypt with the multinational in several universities in Egypt with such idea. So foam guided ultrasound foam sclerotherapy plus compression, of course, versus another arm compression only. And we are waiting for the results. And I would say this is going to be a great breakthrough or a turning point in our practice. So we're waiting for this. Thank you, Erika, for such an excellent demonstration. And now we shall go for your next patient.
Yes.
Okay.
Mr. Pfeiffer, we have this should be just a small presentation about these last spinal cord.
So your patient with socks, this is okay for you?
So me?
Yeah.
So I will display it in the left. Great something is like it.
Yeah.
So we can go back on the different provocation maneuvers. We start here in the groin. You see the walrus here. Very well. Not going
Yeah.
down.
You see it,
I will make it longitudinal.
the band. Yeah.
This one is the epigastric vein. This one is the great submucous vein.
Yeah.
And let me find out. Then this, you don't see
It looks like a focal dilatation of the great saphenous. What do you think?
Yes, there's a focal dilatation in the book.
Could you measure this focal dilation to see how we measure the vein?
Yes, but Basila, the topic today is perforating veins, and I'm running really low. With everybody, it's so much time. This is 11.4 milliliters, which is
1.4.
enlarged. We can make another session about where to measure veins. This is a very interesting topic.
All right, perfect. We try to benefit from your skills as much as we can, Eric.
I know. So we have a lot to do, like, we nice on the floor. First, with manual compression. You see something interesting? The reflux comes behind the two terminal valves. The terminal valves, so we kind of make the image a little bit larger. We redo the thing.
Yes.
It is a deep vein in the femoral opening. This is the epigastric vein, and this is
the great saphenous.
Neck compression thing. Here is why let's say I have Fuß on Ultrasound. So I was in big bus. When he elevated the toe, we had a systolic earflow. Yes? And then he lowered the toe, and we had a diastolic flow from the epigastric vein, and we will work that out through the great saphenous vein, but not from the deep vein. We're going to repeat this. And this is how to evaluate the pre-terminal and pre-terminal valve. So that you can have would like this per se perpendicular horizontally. Gibt es noch mal eine Zehe bitte an und verlassen. Woody. Also now. So repeat it noch mal Zehe und verlassen. So we have the impression that there's no real good reflux at that place. And this is why I have this patient here today. It needs smiling, because my most beloved maneuver is having the patient either sleep to bind in boots. And in this case, we will see a long lasting reflux. We will see, it will wait 10 seconds. It's not schnell out. Spending the frequency English. My own English perfect. Also, she got Russian to last, but not English.
Actually.
We go back to the place, and then you see this the following. You have it. Lazy to know. We have a long lasting flow from the floor.
Yes.
Yes, the real
enormous
amount of flow. I take the TV out, and with the color, we will see where the flow comes from. It comes from the epigastric, and it comes from the coronary.
Great stuff.
Yes, and there, the coronary. And here, the deep vein, the terminal is competent. Yes, it is just flowing around the terminal valve. This was what I wanted to show you a little more. And now we have to have a look where the reflux goes back to the deep vein. So we go down. The saphenous eye. Everybody knows it already. We have a reflux here.
Very prolonged. Yes, very prolonged, very significant reflux. Yeah.
We have a tributary. This is the difference between the perforating vein. The perforating vein would pierce this fascia, and the tributary pierces the superficial fascia, this one, for the fascia saphenous.
Very important point, because sometimes the operator, they got confused between the what pierces the superficial fascia and what pierces the deep fascia. So this is a tributary. This is not a perforator. We have to make it highlighted, please.
Now we go down the Satinos vein and look for drainage funds. And we see, in this case, he has drains and drains always through the tributaries. They go up again, mark. We see no perforating veins here, no significant ones. Here is tributary. So it seems like it's here on what nothing. Right? As the patient is standing again at time, the reflux seems to have been lost. Yes? But there is reflux. When we put him down again and standing, here we still have a significant right seeing it on the top. Well, that's that. Number we see it on the here. So it looks like the reflux goes out the Satinos vein here, and below we do not have any reflux anymore. I will go down the vein and bring down. Now sometimes reflux comes back into the vein, and here this is what I'm going to show you.
Perforator, yeah.
It's a little perforating vein paratidial, and you can see any contrast, and it is draining more. And also you have a big artery here. There, you must always perforating veins, that artery is next to it. This is why it is so very close. Most therapy of the perforating vein in the channel of the perforating vein was to put puncture the artery. But this is a very, very tiny perforating vein draining the healthy segment of the Satinos vein. Here we have another perforating vein. We see it pierces the fascia here. So let us have a look at one recollection. So I want to see it here, all to the perforation. But this one is draining. This is very noticing. You see the growth is draining, and if we apply the first ways, I'm going to see it here. But it's a dissolvent. It is sometimes a little bit complicated to have it displayed in PW2, but in the color it was very obvious. So might see it on water lesson. You see it is joining in red. Then the man have this in background. You see here, yeah, no, wait. Here there are two jellies. And the nearer you come to the alcohol, the more difficult it is to find where they grain really, because it is so difficult to put the probe horizontally on the skin. Then it metal. Sometimes there is a perforating vein lateral, but it looks like only tributary going down. Like that.
Erika, we cannot see the perforator vein.
No, there is not. He has the perforation veins here down in the soul. Within the management. He drains to the top vein here. He goes down, and here at the foot sometimes you don't see it. You don't see the perforating veins of on. Give them I don't see on don't realize it.
And what if you can lower the velocity scale? You have 17 now. If we try to lower a bit, yes, 15.
Nice. Wait.
12, not 10 now, yeah.
Here we saw wing going down. Sometimes if people is really difficult to find things, but I'm an experienced on working lesson. This one would be a perforating. Yeah, yes, we've seen possibly. Can you show on the you have the vein just going down here and it drains like here, huge. That would come over there. Very good foods. This is didactic because normally in clinics it is completely you have if you treat it varicose vein, it's longer than that year. So I want to be, you know, want to be blessed. Okay, so there is sort of very like tributary in the submachine vein. There. And medial recursion.
Yes, we can see it now. Yeah. Because the compartment here between the posterior tibial veins at this level is very shallow, so the perforator itself is very short, it's very small one. Yeah, absolutely.
So this one was the non-axial reflux, and I wanted to with integration because of the maneuver. Yes, that we saw that there is regular reflux in all the maneuvers, but in lying down and standing, there is a really a large reflux. So this was what I wanted to show at this stage. In fact, was precisely it was a quick presentation. What we please make all questions now? One on
The Paul, please wait for the second Paul, please.
get down.
Now the second Paul, which answer is correct? And just single choice. Number one, dilated perforating veins have to be interrupted. Number two, refluxing perforating veins have to be treated. And number three, dilated perforating veins with draining flow in diastole and reduce their diameter after interruption of the reflux source.
I hope everybody
Excellent demonstration, Erika. And this is a good example for Chiba. I would say this is the operator skills, because we can see that the junction, it was purely comes from the GSV, and we have a refluxing, a big refluxive tributary. So if you can do it really, Chiba technique, it will be fine. What do you think?
Yes, I would interrupt the both tributaries and the groin and the thigh and leave the groin untouched.
Yeah.
Because the terminal valves will preserve the reflux. This is the real
And
question.
if we put a scenario that a patient with such a perforator at the distal leg level with venous leg ulcers, what would be your treatment? Because we have a question about the treatment of the patient. But in cases much more advanced, I mean, in the C4, C5, C6, what would be your...
He had a little bit of visible waste, but no edema. So he's still this patient with me already for 5 years, and he has no compliance, so we are not treating him. We could do two things in my eyes. She could close the bread, something is very below the junction to allow that epigastric reflux draining to the deep vein, like you do a manipulator. Yes. I would only ablate the proximal segment of the bread, something in green, or you could do a tributary interaction with both large tributaries at the proximal thigh. If you interrupt them surgically, you can expect that the flow in the dregs of the vein will revert and go behind the cases.
We have the results of the second poll with the 63%, again with the third answer, that the dilated perforating veins with draining flow in diastole reduce their diameter after interruption of the reflux source.